Good afternoon, everyone. Welcome to our webinar. We're just going to give it another minute or two as people are just signing on. We'll go ahead and get started. Welcome, everyone. Thank you for joining our webinar on reimbursement opportunities for food as medicine services, hosted by Food as Medicine Massachusetts, known as FEMA. My name is Jean Terranova, and I lead the Food and Health Policy Initiative at Community Servings, a Boston-based not-for-profit that provides medically tailored home-delivered meals to individuals experiencing critical illness. We're also a co-convener of FEMA, and on the panel you will hear from Katie Garfield, Director of Whole Person Care and a clinical instructor at the Center for Health Law and Policy Innovation at Harvard Law School, known as CHLPI, who is also a co-convener of FEMA. Erin McCready, a clinical fellow at CHLPI, will also be joining as a panelist. Today, you'll be hearing a panel presentation and discussion focused on a broad spectrum of reimbursement opportunities for food as medicine services through partnerships with healthcare payers. The panel is comprised of healthcare payers and policy experts and Massachusetts-based food as medicine providers, and will share their expertise and experience with navigating the Massachusetts healthcare policy landscape in securing reimbursement for food as medicine services through Mass Health's Flexible Services Program, Medicare Advantage, Senior Care Options, PACE, OneCare, and WIC. We hope you'll be able to gain a better understanding of food as medicine services for which reimbursement is now available in Massachusetts. The presentations will address reimbursement opportunities for these services across the lifespan, and the panelists will proceed in the following order. Katie Garfield, as I introduced earlier, will provide an overview of the policy landscape for reimbursement of these services in Massachusetts and nationally. Sonia Carter, Nutrition and Wellness Program Manager at the Boston Public Health Commission, will discuss opportunities within the WIC program for women, infants, and children. Rochelle Bellin, Associate Director at Just Roots, and Sarah Donahue, Director of Clinical Analytics and Community Integration of Boston Children's Hospital, Department of Accountable Care and Clinical Integration, will discuss their partnership to serve fresh produce, cooking tools, and educational resources to families in the Flexible Services Program. Erin DeBacco, and Director of Strategic Growth and Business Development at Community Servings, and Tarsha Davis, Senior Manager of the Medicare Advantage Care Team at Blue Cross Blue Shield of Massachusetts, will share their experience in providing medically tailored meals to seniors through a Medicare Advantage plan. And finally, Marjorie Gann, Chief Operating Officer at Ethos, will address opportunities within the Older Americans Act, state-funded home care, senior care options, OneCare, and PACE. And with that, we will turn it over to Katie.
Hi, thank you, Jean, for that introduction. As Jean mentioned, my name is Katie Garfield, and my role here today is really to set the stage for the rest of the webinar. I'll provide a brief overview of the landscape of current reimbursement opportunities for food as medicine services in Massachusetts, and then really hand things off to our other panelists for a deep dive into their experience in navigating those opportunities for their individual organizations. Next slide. But before I do that, I just want to start by grounding our conversation in what we mean when we say food as medicine. Food insecurity and poor diet quality are key drivers of chronic illness, negative health outcomes, and rising healthcare costs here in Massachusetts and across the United States. For many individuals, we know that a great deal can be done to address the connections between food and health through connection to basic food access resources such as SNAP and food pantries. And these services are therefore a fundamental foundation in this space. However, for many individuals living with or at risk for diet-related chronic illnesses, these services may not be enough to fully treat or prevent the onset of disease. This is why we have seen over the last decade the development of a range of food as medicine interventions. So food as medicine interventions are those services that specifically respond to the critical link between nutrition and chronic illness. Over the last 3 years, FEMA has developed definitions for 4 categories of food as medicine services, which are listed in the upper 4 levels of the pyramid here. They range in intensity, they really differ in intensity and approach depending on the needs of the patients that are receiving them. So at the top of the pyramid, we have the most intensive intervention, often for patients with the greatest medical needs, and those are medically tailored meals. These are meals designed by a registered dietitian nutritionist to meet specific health needs of individuals who often cannot shop or cook for themselves. Then moving down the pyramid, we have an array of slightly less intensive interventions designed to meet the needs of individuals who are able to shop or cook for themselves. These include things such as medically tailored food packages, which consist of packages of minimally prepared grocery items selected by an RDN or other nutrition professional, again, as part of a treatment plan. And then we have nutritious food referrals. These are programs that provide funds for nutritious foods that can be redeemed at food retailers based on a referral from a healthcare provider or plan. And a common example of this category would be a produce prescription program. And then finally, we have the broad category of community level healthy food programs. These are broader programs that provide nutritious food to particular populations at risk for diet-related disease and have some nexus to the healthcare system. So for example, think of a mobile food market at a community health center providing healthy food to patients served at that center. So today's webinar will focus specifically on current opportunities to receive payment for the spectrum of food as medicine services, both inside and beyond Massachusetts' healthcare system. And for those of you who are joining us from other states, I should note that many of these opportunities do exist across the country, but many differ slightly based on the approach taken by your state officials and local healthcare payers. So always investigate your individual landscape if you're interested in taking advantage of these opportunities. Next slide. So what does this overarching landscape look like? Payment opportunities for food as medicine services fall largely into 2 large buckets, our general nutrition program funding and then health insurance funding. On the federal nutrition side, there are 2 key programs that have historically supported food as medicine interventions. First, we have the Older Americans Act, which provides funding for nutrition services for individuals 60 and older, including home delivered and congregate meals. And then we also have, of course, the Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC, which provides specific food packages to individuals who are pregnant, postpartum, breastfeeding, as well as infants and children up to age 5. Then on the insurance side, I'll have you click, Liz. We see a number of opportunities emerging across each of the major categories of health insurance. These categories are outlined on this slide, and they include Medicaid, Medicare, dual eligible programs, PACE, and commercial payers. And while I won't go into detail on each, I'll just give you a general sense of who is served by each of these programs, just to really ground our understanding in this landscape. First, we have Medicaid. This is the health insurance program administered by Massachusetts State Medicaid Agency, or Mass Health, which serves individuals with low income. Next, we have Medicare. This is the health insurance program administered by the federal government and individual health plans that provides health insurance coverage to individuals 65 and older, as well as individuals with certain disabilities. Then we have dual eligible programs. These programs are specific plans and programs that serve individuals who qualify for both Medicaid and Medicare. In Massachusetts, we have 2 programs that specifically serve this population that we'll talk about today. OneCare, which serves dual eligible individuals between the ages of 21 and 64, and then senior care options, serving dual eligible individuals age 65 and older. Next, we have the program of all-inclusive care for the elderly, or PACE, which is a program serving individuals 55 and older who would also otherwise require a nursing home level of care. And then finally, the broad category of commercial insurance. While we won't go in depth into this today, it is worth noting that it exists and has a lot of flexibility that could create opportunities for food as medicine interventions. It's really the broad category of health insurance plans, which includes health insurance provided through employers or purchased on the individual marketplace. So next slide. So what are the major differences in these opportunities? They differ primarily in how established they are, which entities operate them, and the populations they serve. So first, looking at nutrition programs such as those established by the Older Americans Act and WIC have existed for decades in Massachusetts and across the country. However, both are somewhat narrow in the populations they serve, really targeting the two ends of the lifespan. Notably, of course, other nutrition programs such as SNAP can address a wider age range, but benefits are often too limited to pay for both basic food access and food as medicine services. And so we often see these two programs, WIC and the Older Americans Act programs, as being a particular, more of a source of funding for food as medicine services. And click. So if we have those two nutrition programs, the OAA and WIC, serving the sort of two ends of the lifespan, we're also now seeing health insurance funding coming in to really fill in the gaps in between, reaching across the lifespan, starting here in Massachusetts with the Mass Health Flexible Services Program, then OneCare, and then programs serving older adults such as PACE, Medicare, and senior care options. Next slide. However, it's important to understand that many of these health insurance opportunities may vary across the state because of the way that they're being built into healthcare law and policy. Unlike nutrition programs, food as medicine services are often not seen as a core part of health insurance coverage. So if we think of the healthcare system as a house, food as medicine services are not necessarily going in through the front door. Instead, they are meaning they are not built into baseline benefits available to enrollees in Medicaid and Medicare. Instead, food as medicine services are essentially getting in through the windows. Individual payers are able to use certain regulatory flexibilities to experiment with paying for food as medicine services. So for example, in Medicaid, Mass Health is using its Section 1115 demonstration waiver to experiment with paying for nutrition and housing supports for certain Medicaid enrollees. Similarly, while original Medicare, so Medicare Parts A and B, don't provide coverage for food as medicine services, individual Medicare Advantage plans can experiment with coverage through flexibilities such as supplemental benefits and special supplemental benefits for the chronically ill. These health insurance funding streams provide important opportunities to serve individuals that perhaps do not qualify for programs like WIC and older and OAA services, or who need more support than can be provided in those programs. However, because they're not built into baseline benefits, availability may vary across the state, with access depending on whether individual healthcare providers or plans in your service area have chosen to cover them. Next slide. And so food as medicine programs should keep a few key questions in mind as they consider participating in these funding streams. A couple of those questions are outlined here. First, I would ask you to consider what types of nutrition interventions can be funded via the program. Some programs cover some types of food as medicine services, but not others. Additionally, programs may serve specific populations. Do those populations and service parameters match your organization's goals? Second, think about what infrastructure a nutrition organization must have in place to participate. For example, if you're looking to partner with a healthcare payer provider, do you have the systems in place needed to sort of accept referrals and process payment? Third, what entity manages the program? And does that entity also manage contracting? Each of these payment opportunities is often managed by a different actor in our state, whether it be Mass Health, individual plans, or other entities. And a first step to partnership will be to figure out who you'll need to reach out to participate. And then finally, questions around, is the funding ongoing or is it part of a pilot? And therefore, are there evaluation requirements? So you may want to consider whether the opportunity falls into the sort of ongoing or pilot program categories. Pilot programs can provide a great opportunity to expand your reach and serve new patients, but they may also change over time. And so are you prepared to shift as needed? Additionally, pilot programs may involve evaluation. Are you prepared to meet any data gathering requirements? So with that landscape and these questions in mind, I think it will be really helpful now to take a much deeper dive into each of these payment opportunities. As Jean mentioned, we'll take them in order of the age groups they serve, starting with the WIC program. So I think I'm now going to hand it back to Jean to introduce our first panelist.
Great, thank you, Katie. And we should have plenty of time at the end for questions and answers. So if you do have questions, please put them into the Q&A section here in Zoom. And we will turn it over now to Sonia. And also just this is being recorded. We will share the slides and the recordings after the webinar. So Sonia.
Thank you, Jean. So again, my name is Sonia Carter, and I'm the Nutrition and Wellness Program Manager at the Boston Public Health Commission, and also the co-chair for the Food is Medicine Community-Based Organization Task Force. Next slide. So as Katie mentioned earlier, she provided a really good description of the Food is Medicine pyramid. And I'm going to share a little bit more about one of the preventative areas here of the pyramid, which is the WIC program, which serves the youngest of the groups that we're going to talk about today. So the WIC program is one of the preventative population level health. So if we could still stay with the pyramid. The WIC program is one of the preventative population level health programs that provide nutrition foods for a population that currently has or is at increased risk for low food security or diet-related diseases as presented here on the Food is Medicine pyramid. And just to give you like a little brief history of WIC and when it was developed and founded, and also for what reason. So the Child Nutrition Act of 1966 was when WIC Congress found that substantial numbers of pregnant, postpartum, and breastfeeding women, infants, and young children from families with inadequate income are at special risk concerning their physical and mental health because of insufficient nutrition or health care or both. The purpose of the program was to provide supplemented foods and nutrition education, including breastfeeding, promotion, and support through payment of cash grants to state agencies that administer the program through local agencies at no cost to eligible persons. The program serves as an adjunct to good health care during critical times of growth and development to prevent health problems and improve women and children health status. Next slide. So as mentioned, the federal government provides federal grants to states for supplemental foods and healthcare referrals. So similarly to the medical meals addressed in the treatment section of the Food is Medicine pyramid, WIC providers receive referrals from healthcare teams, and the WIC registered dietitians and nutritionists prepares medically tailored meals through the WIC packages and offer nutrition education for low-income, pregnant, breastfeeding, and non-breastfeeding postpartum women, and to infants and children up to age 5 who are found to be at nutritional risk. Next slide. As mentioned before, Congress authorizes a specific amount of funds each year for the program. The USDA Food and Nutrition Services administer it at the federal level. WIC operates through 1,900 local agencies in 10,000 clinics, sites, 50 states, health departments, 33 Indian tribal organizations, the District of Columbia, and 5 territories: the Northern Mariana Islands, American Samoa, Guam, Puerto Rico, and the Virgin Islands. About 89 WIC state agencies administer it through approximately 47,000 authorized retailers. Next slide. So as mentioned earlier, these are the service area WIC provides. WIC is also found in many locations, and the most are hospitals, county level health departments, community centers, health centers, schools, and community action agencies. And there are now some mobile sites as well. In addition, if you speak with a WIC program in your area, they will also come out to your location to sign people up for the WIC program. The WIC team include a senior nutritionist that is always the dietitian. There's also a nutritionist, a paraprofessional, breastfeeding counselors, community coordinators, family support coordinators, and board certified lactation coaches. Participants can access WIC services via an online WIC application that is then uploaded to the site associated with the zip code. Certification occurs virtually through video appointments that include online nutrition education. Participants can take a screenshot from their health portal to share health data such as height, weight, and hemoglobin results. And participants will then receive benefits for 3 months. And recertification occurs every 6 months. Well, WIC eligibility is determined by income and if you're at nutritional risk, as mentioned earlier. And you're also financially eligible for WIC if you are on SNAP, which is the Supplemental Nutrition Assistance Program, or if you're on Medicaid. Next slide. This is a snapshot of the WIC food package for children and women, for children ages 1 through 4. As you can see from this list, participants have access to an extensive list of food products from the category shown here, including foods such as tofu. What is not shown is the infant food package. As you can see from the WIC team presented earlier, WIC focuses on breastfeeding and provide the necessary resources to women who are interested and can breastfeed. However, the WIC food package offers infant formula and introduces infant cereal, fruit, vegetable, and meat at 6 months or as developmentally appropriate for the child. The nutritionist meets with the mom to determine the appropriate food package depending on the nutrition needs of the mom and child. The height and weight and hemoglobin data are reviewed to ensure they are within normal limits and to provide the appropriate nutrition counseling. Next slide. So in the past few years, WIC has responded to 2 major crises, COVID-19 and the formula shortage. During COVID, WIC responded by increasing the allowable options for foods such as eggs, yogurt, and cereal, and included additional options for different brands of whole grain bread. In addition, WIC participants could use the self-checkout lanes at stores such as Price Right, Shaw's, and Star Market, Stop and Shop, and Walmart Supercenter. During COVID, some WIC locations reported lower participation, which they attributed really to the increase of SNAP benefits. However, WIC addressed this concern and developed resources recommending how WIC participants could use their WIC and SNAP benefits together. One recommendation was to encourage participants to use the SNAP card to purchase food they could not buy with WIC. And examples of those foods include such things as like cooking oil, spices, baking ingredients, healthy snack, meats, and frozen meals. In addition, reminding the WIC participants that they should use their benefits, the WIC benefit first, and then use the SNAP benefit. Next slide. So there have been an increase in the WIC food package during COVID. It is a temporary increase until September, but hopefully they will continue with this increase, which includes $24 for children, $43 for pregnant and postpartum women, and $47 for fully and partially breastfeeding participants. The current the farmers market coupon is worth approximately $30, and participants can receive these WIC coupons from the WIC offices. Last year, they were able to mail out the WIC coupons to participants, but I'm not sure if they will be able to do that this year, primarily because of funding. Next slide. So obviously, I'm sure everyone has heard of the formula shortage and what occurred. This started in February of this year. The formula shortage really presented a major emergency. The Department of Health requested and received 3 federal regulatory waivers from the USDA that provided additional flexibility in response to formula shortage. to allow the program to cover other formula brands and other than Abbott without medical documentation, to use non-standard container sizes, and retailers could exchange recall formulas purchased with WIC benefits for non-identical but similar formula products. WIC was able to add 8 more formula brands, including Mead Johnson and Gerber products, as well as a full range of private label store brand options. Mass Health made accessing medically needed formula easier for members and providers by waiving prior authorization and pharmacies for members with a prescription. And the Division of Insurance and Mass Health are directing health plans to waive any prior authorizations for formula needed for medical reasons for 90 days to prevent undue delay in members' access to specialty formulas. So in conclusion, WIC data, next slide. This is like really a snapshot of WIC participant and food costs. For the fiscal year 2019, states reported an average monthly participation of over 6.4 million. The data shown for Massachusetts is as of May 13, 2021. You could find this data from the USDA Food and Nutrition website, monthly data, state level participation by category and program costs, the data tables. Just drawing your attention a little bit to the $34 that they have here that is mentioned as the average monthly benefit redeemed per person. However, the value of a food package is approximately $60 to $100, depending on the need of the mom and the child. And this low redeemable cost per person can probably be attributed to the possible the WIC participation levels that dropped during COVID. Currently, WIC is working on creating a hybrid model and online ordering through Walmart. So that's it. Thank you.
Great, thank you, Sonia. One quick question in the Q&A before we go on. Is what do you mean by a WIC authorized dealer?
Not every store, or such as supermarkets or like community stores are authorized to sell WIC packages. They need to become authorized by WIC to do so, and that is done through like each state level department. So the Department of Public Health.
That's great. And just one other question is, can you clarify what is the hybrid model?
So the hybrid model will also allow participants to not only do the online application, but also now also just ensuring that they could also complete the WIC applications at the different WIC locations.
Great, thank you so much. That was great. Okay, so next up are Sarah and Rochelle on the Boston Children's Hospital Accountable Care Partnership.
Thanks, Jean. This is Sarah. We'll be talking about our flexible services program through Mass Health, the Medicaid program in the state of Massachusetts, and it's called Farm to Family, a partnership providing farm fresh food for pediatric patients at a household level. Next slide. I'll start with an overview of Massachusetts Flexible Services Program. It was launched in 2020 as part of the 1115 waiver that Katie referenced in order to pilot whether accountable care organizations can improve patient health and reduce total medical expense by addressing one or two of health-related social needs of housing insecurity and food insecurity. And Mass Health requires that the accountable care organization do this work among patients with certain health conditions, and their long-term goal is to promote health equity. Next slide. So BCH ACO, Boston Children's ACO, is really enthusiastic about having this opportunity to pilot new ways of responding to patients' health-related social needs. We are essentially a pediatric accountable care organization in that the majority of our patients are under age 21. And so we have a unique perspective on delivering these services, and that's a bit different from the other ACOs in our state. The rules of the program are the same for all ACOs. So in order to qualify, the member must have at least one of the defined health needs, which the ACO is allowed to select, and be experiencing either food insecurity or housing insecurity, depending on the program. We selected behavioral health symptoms and conditions as our initial health need for the eligibility criteria for two reasons. One is that the prevalence of these symptoms and conditions is quite high in our population. It was 40% at the beginning, and now it really probably has increased a little bit more during the course of the pandemic. And we also know that these symptoms and conditions are associated with food insecurity and housing insecurity. So become more intense with food insecurity or housing insecurity. And so hypothesizing that if we intervene in those areas, we might see some reductions in those symptoms and conditions. The funds that are provided for flexible services can be used to provide services and goods to the participants, and we also are allowed to use the funds for the administrative costs of delivering services. We can partner as an ACO, we can partner with a social service organization who's external to provide the services, and or we can pay ourselves if we provide the services directly. So we'll be talking today about a partnership with an external organization. And as is common, this program is the payer of last resort, and we are required to ensure that we're not duplicating existing services. Next slide. So as I mentioned, our BCH ACO, that's our acronym, really views this as an opportunity that aligns very well with our overall working strategy for health equity. I won't go through this whole diagram, but the mission in this strategy is to promote health equity by reducing the social barriers to optimal health and well-being for all children. And I've highlighted in this red box that one of our strategies is to test and implement equitable and consistent response to health-related social needs. So it's really important for us to have some resources in order to develop those systems and programs. Next slide. So we set out to develop the flexible services program and used a process that's been informed by internal stakeholders and external experts, among others. The overall process is in our identification of programs is informed by several factors. One is our data about the population. Next is the evidence base on response to health-related social needs for this pediatric population. We consider any related efforts that are occurring at our hospital or with other affiliated providers, and we include provider and patient family feedback on the possible options and as we are implementing as we revise. So initially, we followed this process. So we reviewed the data on the characteristics of the population, and as I mentioned, that was one of the reasons why we selected behavioral health symptoms and conditions as we were looking at the health characteristics of our population. We also look at the geographic distribution. Our ACO is across the state of Massachusetts, but it is clustered in certain areas. And we also looked at the time at whatever data we could find to estimate the prevalence of food and housing insecurity. We convened a stakeholder group and they gave us feedback on the program design overall, as well as specific ideas for interventions. And then once we had narrowed down interventions, we started to identify potential partners. And we really did that via stakeholder connection. So people who knew folks in the community who were working in this area. Just Roots, Rochelle is here, emerged as a really promising partner for us in this work that could provide an innovative nutrition intervention to our patients, as pediatric patients, and who are essentially in a family unit that we cannot ignore. They are located in Western Massachusetts and can offer that service there. And they were very willing to collaborate with us to refine the program over time. They have had experience with the target population of lower income individuals. They had experience conducting evaluation, and they had worked with healthcare entities. So those were all really great attributes for us in considering them as a partner. Next slide. This is an overall sketch of our nutrition support program focusing on this partnership. We do have other nutrition support programs that use slightly different approaches. So here you can see at the top that we have our population, and again, that pediatric population who have an eligible health condition and are experiencing food insecurity. And the program focuses on both addressing the acute need related to food, as well as attempting through methodology, programmatic interventions to prevent adverse nutrition related outcomes over the long term. So in addressing the acute need, we provide food resources directly to patients, and Rochelle will get into that. And on the prevention side, we help families access food-related resources. So for example, as just mentioned, if they are eligible for WIC, helping them get into WIC and other resources. And then we are allowed to provide kitchen supplies. So we offer those to families and provide them with cooking classes and nutrition education. I'll call out the bottom of this graphic, which is a really foundational element of our flexible services program, knowing that it is targeting individuals and families that are low income. We have a component of the program where staff are helping families to optimize their income supports and access benefits for which they are eligible but not yet receiving. So things like the earned income tax credit or SNAP or WIC, just making sure that families have financial resources available to them to help so that they can become more food secure over time. Next slide. Next slide is Rochelle. Off to Rochelle.
All right, thanks, Sarah. My name is Rochelle. I'm from Just Roots, and we are a farm-based food justice organization based in Greenfield, Massachusetts. And we grow food for our local community, and then have had the opportunity over the course of the last few years, because of flexible services, to expand beyond our local community and across the state of Massachusetts. And so I'm going to talk a little bit about what that program has really looked like in partnership with Boston Children's Hospital. So Farm to Family, what we've called our program, is a year-round fresh food access program connecting our local food from our farm and partner farms to folks who identify as food insecure and have other qualifying medical conditions, as Sarah mentioned, through a digital healthcare referral system that we've developed in partnership with Boston Children's Hospital. So at its core, what this program ultimately does is connects folks to both nutrition and also support to make that nutrition accessible and ultimately lead to people eating fresh fruits and vegetables, while also investing in the sustainability of our local economy and specifically our local farmers and farmland. So it's a food delivery program. We're bringing weekly, well-balanced deliveries of the in-season harvest from June through December directly to people's doorsteps, and monthly deliveries of local storage crops, greenhouse greens and herbs, and canned and frozen crops from January through May. So giving folks the experience of eating with the seasons and eating locally year-round. And as you can see, there's 2 different sizes of boxes that folks can choose from to make sure that we're really meeting different family size needs. And in addition to the produce that they're also getting local proteins. So there's vegetarian options and omnivorous options, and folks can be getting chicken, beef, fish, or beans, eggs, dairy, things of that nature. On the other side of things, beyond the actual produce and food options that they're getting, we're providing 2 other significant resources. As Sarah mentioned, they're getting a robust set of cookware to ensure that folks have all the tools they need to cook from scratch. And also, the other is a robust set of cooking classes and educational resources, so folks have the know-how and the support that they need to be cooking farm fresh food from scratch. Next slide, Liz.
And you have about 2 minutes.
Great. I'll quickly go over this. This is just kind of an overview of what the services ultimately mean. So they're getting 27 produce deliveries, a real bounty of fresh produce, 12 protein deliveries, resources in addition to the cookware, which is a really robust set of high quality items from box graters all the way to blenders and slow cookers. We have a team of folks who are there to support people and provide different kinds of education. So that's happening in phone calls in both English and Spanish. That's happening through newsletters and recipes and nutrition information. And then it's happening in twice monthly cooking class opportunities. So you can go to the next, Liz. This slide is to kind of indicate there's two different sides that we think are critical as a part of what we are doing in addition to the actual delivery of food. One, on the left, you'll see a little aggregation of photos. That one is this QR code. It's on every box that goes out. I think you can actually use it right now if you want to check out what's on the other side of that. But that gives people really easy access to understanding with pictures and recipes for every ingredient that's in a box every week. And then all the friendly faces are the people who are behind this program, who are there answering the phones and making sure that every person has their needs met. So we work very closely with the community health worker teams from Boston Children's Hospital to make sure from both sides, the healthcare side and the farm side, that patients are getting their needs met. And then on the right side of here, you're seeing information that we provide to the community health worker teams and the clinics to make sure they have everything they need to make a successful referral. Next slide. I think I'll just point out one awesome outcome. We have really great outcomes that are coming out of this program, but 80% of folks are reporting that they are eating more fruits and vegetables. And I'll say one more because I can't help myself, that about 40% of families are actually reporting that they're cooking more together as a family. Next slide. And that very shortly, 85% of folks are saying that because of this program, they have more resources and money available to meet other basic needs because of the farm to family program. And so all in all, I think this program has been putting a lot of money from Mass Health into local farms and providing really deep impacts to the health and fresh food availability for over 150 Boston Children's Hospital ACO patient families. All right, I think I can wrap up there. Thank you.
Great, thank you. That was great. Next, we're going to hear from Marjorie Gann from Ethos about meals for adults.
I'm Marjorie Gann. I'm the Chief Operating Officer at Ethos, and we run the Meals on Wheels and Community Cafe program for the City of Boston. Next slide, please. And meals for adults are certainly the longest and most traditional target group for medically tailored meals. And we can do these as either home delivered or as group meals at senior centers or other community spaces. And we think of our meals as being medically tailored, but also culturally appropriate. Probably our typical consumer is in their 80s, and we really want them to eat their food. No nutrition if they don't eat it. So we really try to be culturally appropriate. We also feel that our meals are more than a meal. We're looking at that individual who's receiving the meal and seeing if they're different than today than they were yesterday. And we're also looking at being able to do more than a meal. And a prime example of that is during the pandemic, we've distributed 900 COVID test kits with meals. And this is to a group who traditionally or typically are a lot less internet savvy. And the sort of standard government approach to the COVID kits has been, well, you can sign up online. A lot of our consumers don't sign up online. Our meals meets federal and state guidelines for calories, protein source, by which I actually mean whether it's a solid muscle meat or a ground meat or an alternative protein source, percentage calories and fat, amount of sodium, vitamins A and C really as indicators of nutrient density and fiber. Next slide, please. The grandmother of the home delivered meals program really is the Older Americans Act, as Katie noted, and that is over 50 years old. The federal meals program set the nutrition standards for most programs in the state that are publicly funded. So what that means is that no matter what your funding source is, if it is public, the meals really are not only meeting the same nutritional guidelines, they're also probably the same meal. So again, one driver, geographically sensible routes, but also that driver doesn't know who the funder is, whether it's a means tested program, an income tested program or not. Under the Older Americans Act, recipients must be 60 years old. There is no income test if you are strictly in the Older Americans Act meals, but the individual must be unable to prepare at least one hot, nutritious meal daily and be unable to leave the home without significant difficulty. So the bar to receiving those meals is fairly high. We also have a community nutritionist who is a registered dietitian nutritionist, and she's available for in-home nutrition assessment and medical nutrition therapy. Our community cafe meals, which in the federal lingo are called congregate meals, which is a terrible name. But those meals are available throughout the city of Boston. We have over 40 meal sites. And in general, in other communities, they're at senior centers and other sites throughout the rest of the state. I would like just to note that the Older Americans Act requires that donations are requested for all Older Americans Act services. However, services continue whether donations are given or not, but we are required to ask. If the request for the donation upsets the individual, we can suppress that request. Next slide, please. So we have the base program being Older Americans Act. We also have meals available under state-funded home care. And if you are eligible for state-funded home care, this is where that meal would be paid for. State-funded home care does not have income limits. The eligibility is based on functional impairments, things like, can you bathe yourself? Can you dress yourself? Can you go shopping for yourself? Age is 60 plus. However, it can be less, be a lower age if there's a diagnosis of dementia. Based on need, home care can provide case management and a really wide range of services. Homemaking, assistance with bathing, home delivered meals, what it takes to keep older adults at home rather than an institution. The agencies that provide state-funded home care are called Aging Services Access Points, and each one serves a distinct geographic area. Next slide. Digressing from that type of program, I want to talk about the program of all-inclusive care for elders, which Katie referenced, PACE. It's also known as a nursing home without walls. And this is a program where if you have Mass Health and Medicare and you are nursing home eligible, and there is a PACE program in your area, you might be eligible. PACE is unusual in the Mass Health programs in that there is a Medicare plus self-pay option. You can opt for this program if you are not eligible for Mass Health. Really unusual. Participants are age 55, so younger, live in the community. They receive most of their services at the PACE Day Center. And PACE is a managed care program. What's unusual is that the medical care is provided by their own staff. The long-term supports and services are provided by the program. And it's a complete soup to nuts program. They do purchase their own meals. In the day center, people would receive lunch and snacks. They can buy home delivered meals from local Meals on Wheels program. However, PACE programs are not universally across the state. They have specific areas. And an example would be in Boston. There are several, but there are other areas of the state where there are none. Next slide, please. Senior Care Options. Senior Care Options is a program that requires either Mass Health Standard, and by the way, Standard is the highest level of Mass Health, has the most services. Generally considered to be a program for very low income people, but it can all for both SCO and other programs. If someone is in fact very frail, there is a waiver that would allow for a higher income. SCOs also can have Mass Health Standard plus Medicare. So either Mass Health alone or Standard plus Medicare. They're integrated, managed care programs combining medical care, long-term supports and services, and the age for folks in this kind of program is 65 plus. So again, because of the Medicare, 65 plus. There are 6 SCO programs in Massachusetts. Each one has its specific service areas, and these are done by county. And the majority of SCOs authorize services through Aging Services Access Points. Generally, SCOs require that individuals are unable to prepare their own meals for the SCO to purchase meals. And those meals, again, are that same Meals on Wheels, daily delivery, with the option of receiving all other services through that meal program. Next slide, thank you. OneCare is the mirror for the Senior Care Options Program. And OneCare is for adults aged 21 to 64. They can stay in OneCare past 64 if that is their choice. SCO and OneCare offer slightly different services, so someone might wish to move to a SCO. Another difference for OneCare is that you can also have either Mass Health Standard or Common Health and combined with Medicare. Common Health is a very specific form of Mass Health that you buy into. There is a premium, and it is for people with disabilities so that they can purchase services that aren't going to be in any other kind of insurance. The most common one in that group is personal care attendant services. Again, OneCare programs are integrated managed care programs that combine Medicare, long-term supports and services. The long-term supports and services could include meals, but again, it's determined by the OneCare program. There are 3 OneCare plans this year. Each one has its own service area, and OneCare programs are not limited to the Older Americans Act meals. They may opt for the traditional home delivered meal, or they may opt for a weekly delivery. Their choice. Next slide. For this group, I really want to talk a little bit about farmers market coupons. Senior farmers market coupons are separate from the WIC coupons or the City of Boston coupons or any other type of farmers market coupon. They are funded through the Mass Department of Agricultural Resources. We get a limited number of those. They are distributed by nutrition projects such as Ethos and other community partners. In Boston, we are really proud of the fact that last year we had a 90% redemption rate. We've had other years with the healthy incentive programs where our redemption rate was actually over 100%. The coupons are $25 per eligible individual. That's this year, 2022. It can vary. They are to be distributed to people who have self-certified that they are low income. And again, there's a flip side program for people who receive home delivered meals where we contract with farmers and we actually deliver the produce with the meal. So they will get a couple of deliveries of fresh Massachusetts produce with their home delivered meal. So, thank you.
Great, thank you. That's really great information. Now we're going to hear from Erin DeBacco from Community Servings and Tarsha Davis from Blue Cross Blue Shield of Massachusetts about their partnership in the Medicare Advantage population.
Great, thanks so much, Jean. Liz, you can go to the next slide, please. Hi, everyone. I'm Erin DeBacco from Community Servings. I think that I won't spend too much time on this slide, but for those of you who aren't familiar with who we are a Boston-based nonprofit with 30+ years experience delivering medically tailored meals. All of our meals are scratch made in our food campus in Jamaica Plain. We currently have 18 healthcare contracts in Massachusetts and Rhode Island and are serving over 4,000 people annually. We partnered with Blue Cross Blue Shield in Massachusetts for a Medicare Advantage contract contract a few years ago, which has evolved and expanded. And as you may have seen from previous presentations where we talked about the food as medicine pyramid, again, our medically tailored meals, we like to say, are the top of the pyramid and the most significant intervention for, in this case, Medicare Advantage members. So those who are over the age of 65 who are unable to prepare meals for themselves at home. And I'm going to go to the next slide and turn it over to Tasha to talk a little bit more about the background of our partnership.
Hi, everyone. I'm Tasha Davis. I am the Senior Manager of our Medicare Advantage Case Management team here at Blue Cross of Mass. We have had a great partnership with Community Servings through our volunteer-based crew called Blue Crew. So we've worked with them for many years before this, and that is how they decided to approach us with their findings and their research on the medical meals and the CHF congestive heart failure diagnoses. So because when we first started with the contract discussions, Community Servings was only able to deliver to a limited part of our population in Massachusetts. So we were unable to kind of put it out there to the world and let them know that we were doing this. So we decided to do a little pilot with our congestive heart failure members. And we partnered with Community Servings with their nutrition department to be able to do nutrition services and the meals. And we did that because we also have a dietitian here on staff to be able to help supplement that and transition them once they leave the Community Servings programs. We also partnered with visiting nurse associations to do telemonitoring with our members to see the impact overall that everyone had. As we expanded with Community Servings, they were able to expand in 2020 their delivery area to include shipping. So now we're able to provide meals to all our congestive heart failure members. And we were able to identify these members through our admission discharge transfer system that we had implemented through Collective Medical. We were able to pick up members that had congestive heart failure diagnoses, not only the driving factor, but in their past medical history for emergency room stays, observation stays, inpatient stays, skilled nursing stays. Through this, we were able to demonstrate to our partners over in our Medicare markets who does our products and was able to align with Medicare implementing the supplemental benefits. So we were able to, in 2021, expand the medical meals through our special supplemental benefits to all members. So they did not now have to have a CHF diagnosis. They could have any diagnosis, and it was post an inpatient stay. So it did kind of limit who we're able to give our meals to, but also expand to anybody that had a post inpatient stay. As we continued through our partnership into 2022, Medicare let us expand to include also outpatient surgeries. So a big driver of our utilization are our elective hips and knees that are getting done and preparing, especially those members that live alone and go home and don't have anybody be able to cook their meals for us. So we are able to provide that and also screen for any insecurities. So do they live alone? Do they have support? Do they have other offerings like assisted living or Meals on Wheels, and be able to drive that social determinant of health? Next slide. So really our objective was to reduce readmissions and really look at the medical spend for these members and focus on those most food insecure members that we have. We outreach and identify these members post-hospitalization and elective procedures, as we know, to offer them these medical meals. So it's 8 weeks of meals per year, and they can split it up through the year. So if they do have a couple of admissions or things going on in planned surgeries, they're able to use that throughout the year. We did when we first started this, it was all emails back and forth and spreadsheets. And now that we have a portal with Community Servings, it's easier to be able to put that HIPAA information through, be able to see where the status is of our referrals and see what's going on. So it makes it a lot more easier. Community Servings has their dietitian. They call, they assess the members, and they check in throughout there. And then if needed, we do have that additional resource here at Blue Cross to follow up with their members. Also during this time period, they are followed by one of the case managers here to check in to make sure that they're doing okay and help with that transition once they complete Community Servings. Next slide. Erin, did you want to do this or was this me?
Nope, this is me. So we just wanted to touch really quickly on some of the highlights of our partnership. So for those of you who are thinking about starting a partnership like this, we really met quite often, and we still do, to talk about challenges or trends and how we can work together to better impact our shared members. We collaborated on working really closely together to develop nutrition education materials. So Community Servings has a pretty vast library of our nutrition ed materials, but we wanted to make sure that we were best serving Blue Cross's specific patient population who may have very specific needs. We looked at like the layout and the font size as well as the content itself. So we worked together on that, which was very successful. And then I think the evolution of our partnership, which we touched upon, the ability to move to statewide shipping. So initially we were getting maybe 100 or under annual referrals, and now we're at over 300, I think already halfway through this year, which is great. So allowing for us to serve many more of Medicare Advantage members through this partnership, and then having Blue Cross starting to use a web-based referral portal, which allows for sort of loop closure and better real-time reporting, which was really helpful for us. And then I'll just note quickly for any CBOs or SSOs who are thinking about partnerships with Medicare Advantage plans, one of the things that for us was had a real impact was the HIPAA and IT requirements to be a vendor or partner with a Medicare Advantage plan for compliance has been time consuming, extensive, and expensive, both at startup and annual. The good news is that now we're in, year 3-4 of our partnership. So we know these things, we build them into our resource planning. And so, it's planned for now, but I think in the beginning it was new to us and took both time and resources to dedicate to understanding all of the compliance factors. Next slide, please.
So we decided to, as we looked at this, we wanted to address the social determinants of health and the lack of access to the nutrition of foods and see how that had an impact on our membership and cost. We also wanted to see if changes in dietary habits to help with signs and symptoms and condition exacerbations would impact on the readmissions and readmission rates, and see how if we gave them those fresh foods and meals, were they able to stay home because they were eating healthier and changing their ways and not worrying about that. As Erin had said, we had started our pilot with such a small population that we really weren't able to evaluate great outcomes or significant outcomes with that. So now that we have 300 plus memberships over the last 2 years involved in this program, now we're going to look at readmission rates that were from the people that got the medical tailored meals versus the non-medical tailored members and what that relationship was. We're going to see how that helped address our health equity outcomes here at Blue Cross and see if we were able to make any reduction in food insecurities and see the impact based on the diagnoses now that it's open to any diagnosis and not just congestive heart failure. Next slide.
Great, thank you. There is a question for Tarsha in the chat, just regarding why you chose to work with Community Servings.
Yeah, so we
Was it
decided,
clear?
as I touched a little bit earlier, we had a great relationship years prior through our volunteer-based program, Blue Crew. So we knew who they were in the community and what their vision and mission was. When they approached us with their research, they were able to demonstrate that they had been making an impact. And since they were a local company, had the research to back up what they were saying, we decided to partner with Community Servings.
That's great. Thank you. Okay, so we're on to our discussion questions here. So this is a question in the chat, actually, that I think Rochelle could kick us off with. What do you recommend for a way to start for farms looking to connect with healthcare partner organizations?
Yeah, I think for Just Roots, I mean, we've done a few things that I think have really helped us expand our network and opportunities to be connecting with healthcare. One that I think has been super fruitful and I think continues to be one of the places where we learn the most, the soonest, and also kind of understand and contribute to the state understanding of food as medicine landscape and vision is the Food as Medicine Massachusetts Coalition. So that's folks who are putting this on, really great resource, really great humans, very accessible, and a really great community. So that's one place. And then there are a lot of healthcare foundations out there that are really wanting to fund this kind of work right now. I would just recommend actually reaching out to those foundations. People take like cold calls and emails. You might not get on their calendar immediately, but we've had a lot of really fruitful relationships that over the years have turned it into funding opportunities or have connected to us to other healthcare partnerships. And then I think also starting small with your local community health center or starting with other folks who are in your local community help build a reputation for us of folks who knew how to do this work. And this is a bit bigger undertaking, but we also did research to back up the fact that we really felt like our program was having incredible outcomes for the community that we were working with. And so we underwent a 2-year clinical research study to be able to walk into healthcare situations and say, we have an evidence-based model and it is ready. Like, we think we can replicate this with your population. So I think as more farms are doing that and other organizations are doing that, it doesn't require that every single organization needs to do such a thing. But I think the more evidence that we all can be contributing to that, the better. But those are a few different ways.
That's great. And actually, that's a great point. And perhaps after that research was published, wasn't it, Rochelle? And so perhaps after this meeting, we can share that, because I do think that leveraging each other's research is a really good strategy as well. If you can offer something similar and leverage the research that's existing, it can really minimize the burden of having to do our own randomized control trials. So great. So here's a question for the panelists. What are some of the barriers in the existing policy landscape to building or scaling the partnerships that you have between food as medicine service providers and healthcare organizations? And anyone can jump in or raise hand, however you want to get this started.
I think I can say for the traditional Meals on Wheels programs, we have pretty good relationships with patient navigators, discharge planners, visiting nurse associations, you name that, the levels, and we get a lot of referrals. And the nice part is that right now we haven't had a waiting list in years and years, which is extremely comforting. And the other piece about our nutrition referrals is they can also lead to referrals for ongoing services. For example, when visiting nurse associations, certified agencies have to bow out when it's no longer an acute problem, we can refer that individual over to state-funded home care and continue those needed services. So that's actually it's a very smooth transition for a lot of those frail older adults.
So has anyone seen, just in terms of just Aaron, I would say the Medicare Advantage landscape, do you see any barriers to kind of the way that the existing policy is to scaling this partnership?
Yeah, I would say one of the things I think we mentioned, but just to make sure, I guess we can mention it again. When community servings were not a statewide, we were not able to serve the entire state. We really weren't able to have a large reaching contract with Blue Cross because they served the entire state. So at that point, it was really a pilot program, and we did not receive sort of the referrals we initially had intended through our partnership. And then once we were able to make the move to be a statewide program, we were able to grow and scale. So I would say that's probably one of the biggest limitations in terms of our partnership being part of the supplemental benefits in their Medicare Advantage offering.
Yeah, and I think just to add on that, as a Medicare Advantage plan, we would love to, we partner with Elder Services of Worcester that does our emergency room visits, and we would love to be able to offer meals to those members because they probably facing the same food insecurities. But unfortunately, right now with Medicare and their regulations on how we can deliver just to the inpatient and stays and then the same day surgeries, we'd love to scale it even bigger and even try to change just chronic conditions again and do that. But right now it is limited to just that. So once CMS allows us to do it, we'll definitely be bringing that to the table.
That's great. And Rochelle and Sarah, how about any challenges that you see with respect to the landscape in the current flexible services program? And maybe you could just speak about, the upcoming waiver extension request.
Sure, I'm happy to start, and Rochelle, I'm sure will add. As I noted, we are a pediatric ACO, and so it has taken a long time for us to navigate with Mass Health when the actual child is the member, not the family unit. But of course, children and nutrition occur in the family unit, whatever that family unit looks like. And so we really can't deliver services directly to the child without interacting with the family and without acknowledging the family unit. So that has been a sort of a mental leap that needed to happen. And Mass Health has in the next waiver referenced household level services, which has been a really nice improvement and good feedback from them based on our conversations with them over time.
Yeah, I think what I would add to that is the two things. One, I think the unknown of the 1115 waiver has been really challenging to particularly operating a farm for us to be able to plan and know that we're scaling in a way that's not going to be like boom and bust. And all of a sudden we've been talking with our local farmers and with our own farm and creating budgets and strategy around that. And then for those programs to just disappear. So I think kind of to Katie's point in the beginning around like we're climbing in a window here, it's like not being able to rely on a door that's going to be open is a little bit scary for smaller social service organizations and farms to be really deeply investing in and building a lot of strategy around. So I would say that piece is a challenge. So excited to see the results that get announced very soon. And then the second piece I think is and I don't know if this is changing in the next waiver, but is the need for annual contracts. There's just a lot of contracting that's happening. And also it happens, again, specifically speaking from a farming perspective, but it happens at kind of inconvenient time of year for us. And so being able to plan in different times of year would definitely be better for us. For any other farms who are on the line, flexible services, it's a great program, but definitely like the cadence and the timing of contracting is a little funky for farms.
Thank you. I have two questions for Katie. So first, kind of, and the second may be related to this, but first is what's on the horizon in terms of addressing some of these gaps and barriers? What is exciting in the future for the policy landscape for reimbursement for food as medicine interventions? And then I'm not sure about this, but the question in the chat is, or in the Q&A is, how do you think the forthcoming CMS Innovation Center ACO REACH model will open new opportunities for partnerships between healthcare providers and health plans and FIM organizations?
Sure. So taking the first question first, I'll start by just reiterating a point that I think Sarah and Rochelle have already made, which is that sort of one of the most exciting things in Massachusetts, from a future opportunity perspective, is the hopefully continued and expanded flexible services program under the waiver. Yes, there was a proposal to extend the waiver, renew and extend the waiver, submitted early this year to CMS, and so we are waiting to see CMS approval of that. But it does a number of exciting things. As Sarah mentioned, there's a proposal in there to allow nutrition interventions to be provided at the household level within the flexible services program. There's also a couple of other expansions, and so we're very hopeful that will be approved, and we're hoping to hear soon. So we will hear more on that in the coming months. So that's sort of a big one for the state. I think there's also a lot of energy in this space at the federal level that could ultimately have impacts within the state. So I think, as many people on the call are probably aware, there was recently announced an upcoming White House conference on food, nutrition, and health. And so this is the first time in about 50 years that we as sort of a country have really focused in on these issues at the federal level in one particular event, and it's going to be happening in the fall. And the Biden administration has been holding a series of listening sessions, virtual listening sessions for different regions around the country to really hear community input on what we think are sort of the biggest places for bold policy action in this space. And I think from the listening session that I attended, I think food as medicine is clearly a part of that conversation, because if there's something that really connects nutrition and health, I think it's many of the services that our panelists have been talking about today. And so I think we're hopeful to see the recommendations coming out of that conference, including some policy changes that could expand the opportunities that you've heard about today. But that remains to be seen. We do know that essentially a set of recommendations will be announced at the conference. And so if anybody on the call has not provided your input towards that, I highly encourage you to do so. And after I stop talking, I'll drop the link in the chat where you can actually go and sort of submit essentially public comment to the group that's organizing that. So I think that's a big it's a good sign that there is federal attention to these issues. Additionally, I think there are a couple of pieces of legislation moving at the federal level that could create new opportunities. For example, the Medically Tailored Meal Demonstration Pilot Act of 2021. That's a piece of legislation that would actually create a pilot in Medicare Part A to experiment and evaluate the provision of medically tailored meals to certain individuals, which would be really exciting because we know one of the biggest reimbursement gaps in this space right now really is that original Medicare population, right? We're seeing Medicare Advantage provide some really exciting opportunities, as we've heard about today, but those same opportunities don't necessarily exist for the 60% of Medicare enrollees that aren't enrolled in Medicare Advantage. And so I think it's really exciting to see some policies that could start to fill that gap. And then hopefully there's also, of course, always the opportunity to see more movement in this space from CMMI, which I think Christina brought up in her question about the ACO model. I think, up to this point, the Center for Medicare and Medicaid Innovation has thought about social determinants, but often in a sort of screening and referral capacity. So with its accountable health communities model, which really provided grants for a demonstration project to test out improving screening and referral to services like nutrition services, but not really for the benefit, the actual services themselves. We would really love to see CMMI sort of reconsidering that and thinking about how do you actually provide funding for the services themselves. We've seen that a little bit in its value-based insurance design model, the VBID model in Medicare, but it would be really great to start seeing similar funding being built into other models. And Christina, I know you have asked about the ACO REACH model specifically. I'm happy to dig into that and chat with you offline about it. I'm not 100% sure of all of the pathways there, but I'm happy to dig in and follow up.
Thank you. So this is a question for everyone. What would you suggest as a first step for any organization looking to take advantage of the reimbursement stream you've described here? So any websites, any resources to read, any, coalition building, those along those lines?
So some additional resources about these particular funding streams. I'm happy to drop a couple of reports that Shilpi has put together in the chat that give a little bit more explanation in sort of a nice place about these different programs. But I also think some of the other panelists probably have great ideas of sort of where do you go first also for partnership.
Mm-hmm.
We just put out an RFP for meals and specifically did outreach to smaller providers in the state and I'm sorry, in the city, and had a remarkably low response to it. And I was really taken aback. So I think that one place to look at, it depends where you fit on the spectrum. For example, if you're a farm, you don't really fit directly into the medically tailored meals, but do you want to talk to those folks who are actually preparing those meals? That's one place to go in terms of selling the produce. If you are preparing meals, it's talking to the folks who are actually in this business, because I really felt for Rochelle when she was talking about how hard it is to predict and frankly, the billing on any of these, when you're working with any of these insurers, the billing is a bear. It's incredibly complicated. They want it electronically. They want it this way, that way, some other way. You got to have the right code. I mean, it goes on. And if you are not set up to do that kind of billing, it's an utter nuisance. So I think reaching out in some cases to your local Meals on Wheels program for a little guidance would be one good, easy place, frankly, to start.
Great. I'm curious to hear from our payer friends, Tarsha and Sarah. What do you look for in a partner, and what are these administrative issues a barrier to partnership?
Absolutely. There's definitely, and Erin, you probably speak to this a little bit more being on your side with the risk assessments that need to be done, and the way they can protect our membership's information with HIPAA and things like that. So if you're a small company that really can't pass these risk assessments, it's going to be very hard for us to contract with them. Erin, do you want to add anything?
Nope, just if you want more information, I'm happy to answer some questions, or my colleagues will, but it's a lot. So you're definitely going to want to know what you're getting into and assess that first.
I definitely see that. I think though that sort of the good news is that providers like Community Servings and Ethos work with local, producers, and so there could be an avenue in which you're a subcontractor with one of the organizations, as Marjorie just said, that's providing the services so that you're not dealing with the administrative burden of dealing directly with the healthcare payer. So you're, obtaining the benefit of, someone else having to do the administrative work with the payer, but you're still able to sort of provide your farm produce, et cetera, to the direct contractor with the payer. That's just one idea.
Yeah, I agree. And our flexible services has actually been a bit more flexible because it's, going through one of those windows, and it doesn't really have, it has many parameters and regulations, but there is some room for exploration. So I think part of it is really being able to partner with an entity that's willing to try out a couple of things and see, and sort of we've done a lot of band-aids and workarounds and try a new way of, sharing the information. Okay, learn from that. And so I think having that open-minded PDSA cycle mindset in this work can be very important, especially for programs where the parameters are not fully set yet. And so being able to come together with the two organizations to kind of design what those objectives are and then test and then keep evolving over time is really important.
That's great, thank you. Great, well, I don't see any more questions in the Q&A or in the chat. And so we're very close to time here. So I want to thank everyone. I want to thank our panelists for joining. This is really great information. As I mentioned, the slides and recordings will be available to everybody who attended after the meeting, and certainly reach out to us if you have any additional questions. And I hope everyone has a really nice summer. Even though it's 68 degrees, it has officially begun. So thank you, everyone.
Thank you.